You're listening to the Journal Watch podcast for the week ending August 1st. I'm Joe Elia. We offer a brief roundup of the week's essential medical news, the terribly important stuff, plus an interview. This week we talk with Professor Michel Ovize about his research on reperfusion injury after myocardial infarction. If you'd like to leave us a comment, you know you want to, call 617-440-4374. Links for everything we discuss here are available at podcasts.jwatch.org. Okay, here are the week's essential medical stories very briefly. Pregestational diabetes. There are new guidelines for chronic lymphocytic leukemia and encephalitis. And hormone replacement therapy. Now for some details. Women who have diabetes before pregnancy are 3 times as likely as non-diabetics to deliver a baby with a birth defect, and almost 10 times as likely to deliver one with multiple defects. Writing in the American Journal of OBGYN, the authors say the importance of detecting, controlling, and of course, preventing pregestational diabetes can't be overstated. Next, leukemia. Chronic lymphocytic leukemia, to be precise. It's the most prevalent adult leukemia in Western countries, and its National Cancer Institute Working Group guidelines have been updated, last update 12 years ago, to reflect the availability of new chemoimmunotherapies and cell markers. The guidelines have been updated to help those treating the illness in the context both of clinical trials and general clinical practice. They appear in the journal Blood. A preliminary draft was apparently released online 6 months ago. Next, encephalitis. IDSA, the Infectious Diseases Society of America, has just published the first guidelines for the diagnosis and management of this most serious inflammation. Writing in Journal Watch Infectious Diseases, Stephen Baum says that although few infectious diseases practices encounter encephalitis, these guidelines provide a useful reference. They're published in the journal Clinical Infectious Diseases. Finally, postmenopausal hormone therapy. The North American Menopause Society has just updated its position on postmenopausal hormone therapy. In brief, treatment of severe to moderate vasomotor symptoms remains the primary indication for hormone therapy, and the Society's statement includes a discussion of talking about this therapy with patients. The guidelines are free, and the link is at podcasts.jwatch.org. And here is the Journal Watch interview. This week, the New England Journal of Medicine published a paper about what happens when you send blood back into myocardial tissue during an intervention like stenting. It turns out that reperfusion can actually cause injury starting at the subcellular level. In fact, within that all-important organelle, the mitochondrion. If protein pores in the mitochondrion's inner membrane open during reperfusion, out pop all sorts of substances that can cause cell death, thus widening the area of the infarct. So, perfusion has got to be done carefully. It's not just an exercise in plumbing. Who knew? Some drugs, antioxidants and calcium channel blockers, for instance, have been tried against this problem, but without much success. Well, along comes a team from Lyon using cyclosporine, et voila! Infusing cyclosporine just before reperfusion limits the reperfusion effect by somehow keeping that mitochondrial pore closed. So, we've asked Professor Michel Ovize, the senior author on the NEJM paper, to help us sort this all out. Dr. Ovize is at the University of Lyon, where he is Professor of Physiology and Cardiology. Thank you for joining us, Professor Ovize. Bienvenue.
Thank you.
Well, your paper emphasizes that this is a small pilot study, but it's very intriguing. Without going too deeply into the molecular biology, why do you think cyclosporine works?
Cyclosporine A is an inhibitor of the mitochondrial permeability transition pore, and this pore has been known for quite a long time now to be involved in cell death after ischemia and reperfusion. It has been showed in many experimental preparation now for years. And we know that when this pore opens at the time of reperfusion, it increases the irreversible damage to the tissue. So we also know that cyclosporin A is a natural inhibitor of the opening of the pore. And experimental studies have showed that when you inject or administer cyclosporin A in vitro or even in vivo, you are able to limit tissue damage after reperfusion. Therefore came the idea that we might try to use it in humans in this specific setting of acute myocardial infarction, and this is what we did, in fact, in that small pilot study.
I see. And what is it inside the mitochondrion that's released by that pore that's so damaging?
In fact, there is two explanations of the mechanism of the damage. First of all, when the pore opens, as you said, it releases several factors that activate the apoptosis, that is a type of cell death.
Yes.
But also, the other important factors, and which is, to my opinion, more important in the present case, is that when you open the pore, the mitochondria start dysfunctioning. That is, it does not produce ATP normally, first of all, and it also instead consumes ATP instead of forming ATP. And after ischemia, in which condition ATP is already decreased, this may lead to energy deprivation to the cell, as well as calcium imbalance. And all these abnormalities may lead to cell death also. Therefore, you have two factors. First, activation of apoptosis and activation of necrosis.
I see. So the ATP actually in the depletion or the change in the metabolism of ATP is what's
Yes.
driving one of the bad effects here.
Yeah, absolutely.
I see. Okay. And the editorial in the issue with your paper says your results confirm the existence of myocardial reperfusion injury in humans. Was that ever in doubt?
Yes, it was. It's been very much debated for years now, because for approximately 10 to 20 years, some investigators believed that there was tissue damage at reperfusion, whereas others did not. And there was some evidence from in vitro experimental preparation, but it was very difficult to prove it in vivo experimental preparation, and it never been proved in humans so far. So we had to have an intervention that would be done at the time of reperfusion and would limit infarct size. And this has never been shown before in humans, except for two interventions. The first one is called ischemic post-conditioning, and we published that a couple of years in Circulation.
Yes.
And the second one is cyclosporin A. Why is it important? It is because we administer this intervention at the onset of reflow. And this is what is very specific. If you want to demonstrate that reperfusion can kill cells, you have to be able to demonstrate that a given treatment administered at that particular time would prevent this noxious effect.
Now, according to your calculations, you were able to limit the infarct size by about 40%. Is that right?
Yeah.
And experimental studies, and this bears out what experimental studies show, I think, is that infarct sizes, I think, in mice or in other experimental animals, were decreased by about half.
Mm-hmm.
And so this is a confirmation in humans of
Yep.
this effect. So it also, according to the editorial, and I'll ask you whether your opinion, whether you agree, stroke, cardiac surgery, and transplantation might also benefit from this kind of an approach. Do you think, on the verge of a wider use of drugs like cyclosporine to reduce surgical injuries?
Oh, sure. I think probably the more important and interesting other target may be stroke, as you said, in which you have the same sequence of event, that is ischemia and then hopefully reperfusion, although reperfusion in stroke is unfortunately quite rare. But anytime in an organ you have ischemia plus reperfusion, you have reperfusion injury. And in these conditions, it's been shown in experimental preparation in mice, in rats, and etc., that both post-conditioning and even cyclosporine A can reduce tissue damage in the same condition, even in the brain. This has been published in animals, and I think it's probably the next step in clinical research.
Well, what's next? Are you setting up a larger trial? You suggest that you may be at the end of the paper.
Yeah. There are several things are next. The first more important thing is that we want to build a morbidity mortality trial using post-conditioning. We are also in the process of starting a trial with cyclosporine A on top of thrombolysis instead of revascularization by PCI, by angioplasty, which is another clinical condition. As you know, people with acute myocardial infarction can get revascularization in two ways.
Yes.
PCI, the one we investigated, and the other one, which is thrombolysis. And this represents a large number of patients also. So we want to know whether cyclosporine A may also be efficient in these conditions. So that's for the next few months.
And then there are there relatives of cyclosporine A that you could also investigate? Yes. There are.
I think yes, there are different possibilities. The first possibility is to find analogs, pharmacological analogs of cyclosporine A that would act on the same molecular target and be different, be deleted from their immunosuppressive activity, for example. Or another direction is to use other drugs that may act on specific cellular pathways that are involved in the regulation of the opening of this transition pore. And we know from experimental data that we have good candidates for that.
Good. Well, I know that cyclosporine has got some side effects that you'd rather
yes.
not see in some of these patients, and so
yes,
I understand that you're pursuing this other all possibilities here. Well, thank you so much, Professor Ovize, for talking with us today.
It was a pleasure. Thank you.
Finally, this week, the journal Cell is grabbing some of the pre-Olympics related headlines with a story about mice that achieved fitness just by taking a pill. No exercise involved, apparently. The New York Times ran with it. At least somebody's getting some exercise. Above the fold. I'm suspicious. Let's screen the little critters for steroid use. If you'd like to talk about any of this or anything else, call 617-440-4374. Just leave your name and number so I can get back to you and get your permission to put your comments on the podcast. Links for all stories are available at podcasts.jwatch.org. Included there at podcasts.jwatch.org, you'll also find links to previous podcasts in this series. Thank you for listening. For the Journal Watch podcast, I'm Joe Elia.